Assessment of Mental Status, Mood, and Behavior. This program is presented by the Beacon Institute through a grant from the Maryland Office of Healthcare Quality. It will review the assessment of mental status, mood, and behavior. As changes in mental status are a major reason for residents to be transferred to the hospital, it's important that we understand how to recognize these changes early so that treatment can be sought and hopefully unnecessary transfers to the hospital avoided. Before we begin today's topic, let's just take a minute to review some key points from the program earlier in this series that presented an overview of assessment so that we can keep these things in mind as we explore this topic. OBRA laws are the federal regulations that require that we provide care and services so that each resident can attain and maintain his or her highest practicable level. COMAR, which are the Maryland regulations, echo what OBRA laws state, but have additional requirement for the nurse to check residents daily for any change of condition. If a change is noted, the nurse must assess that change. Assessment is the first step in the nursing process and involves the collection and analysis of data. All other steps of the nursing process must relate to information from the assessment. Assessment upon admission or readmission establishes a baseline necessary for future comparison to determine the extent or nature of change. Nursing documentation must be objective versus subjective. In other words, it must state facts. This program should enable you to identify the components of mental status evaluation, identify standards for the frequency of mental status assessment according to niche, identify and discuss skills needed to collect appropriate data for mental status, mood, and behavior assessment, discuss at least 3 factors that can influence the quality of data, name at least 2 standardized tools for data collection related to mental status and their reason for use, distinguish among dementia, depression, and delirium, identify at least 3 things to consider in the evaluation of mental status change for concurrent review, and describe and discuss data collection and analysis of behavior to determine a trigger. Okay, let's begin. We'll start by defining some terms that we'll be using. Mental status refers to a description of a person's mental awareness, alertness, and function based on observations and interview. Included in this is orientation, judgment, memory, problem-solving ability, mood, behavior, and one's contact with reality. Mood is a state of mind, feeling, or emotion. Behavior is the way in which a person acts or conducts oneself or a response of an individual to his or her environment. If there are problems in any of these areas, it will affect overall care. It affects how we approach the resident, it affects how the resident will respond, and it will affect overall outcome. Dementia, delirium, depression. Generally, the residents that we care for in long-term care are at high risk for all of these conditions. Remember that we are tasked with helping each resident attain and maintain their highest practicable level, and this includes their mental and social functioning. It's important to screen residents to identify the presence of any impairments and to monitor over time to determine if there is any change. NICHE, which stands for Nurses Improving Care for Healthcare System Elders, is the leading nurse-driven program designed to help hospitals and healthcare organizations improve the care of older adults. In the overview program, you may remember that we discussed the importance of doing assessments upon admission. Everyone agreed that assessing at that time was very necessary so that a baseline could be established. In reality, though, how many of us are actually doing mental status evaluations upon admission? If such an assessment is done, Sometimes it's done by social work, not nursing. If assessing mental status for a new resident, it's important to validate your findings with someone who knows the resident well. New admissions who have been transferred from the hospital are at high risk for delirium, so it's important to make sure that what you are seeing is not a new change. Let's look at the remainder of these recommendations and talk about the benefits of doing a mental status assessment at these times. Let's discuss data collection for assessment now. The overview program also discussed that there are multiple ways to collect data, including measurements, auscultation, palpation, and so on. Mental status, mood, and behavior cannot be measured using those types of techniques, so we have to utilize our observation and interview skills. When we collect assessment data, such as vital signs, wound assessments, and so on, that process and the results are pretty much black and white. We use technical skills and get exact results. However, when your data collection method is interview and observation, you are using soft skills or people skills. Part of the skills you use involve the awareness of and how to read a situation. There are a number of things that can influence the quality of the data that you obtain. Assuring that the resident is comfortable, and very important, as well as making sure that the person can understand and is understood. It's helpful to review information about the resident prior to the interview. This can help you to identify memory and cognition problems if the resident's answers are not consistent with what the record shows. It can also help you to understand the context of the resident's responses in terms of the person's life experiences. For instance, sensory deficits can be responsible for paranoid behavior. It's important to appropriately prepare both the resident and the setting for interview results. This can include things such as it's important to appropriately prepare both the resident and the setting for the best interview results. This can include such things such as scheduling according to the resident's best time of day, making sure that the resident is physically comfortable, looking at the environment to make sure it's free of distractions and has adequate lighting, being sensitive to the resident's sensory abilities and positioning yourself accordingly, preparing the resident ahead of time for the assessment, initiating the assessment with non-threatening conversation, and letting the resident set the pace, giving enough time for responses. There are various tools available to collect data related to mental status, mood, and behavior. The use of these tools helps to standardize our responses to increase objectivity and consistency. Those listed here are just examples of tools that are available. You will find copies of some of these in your toolkit. Others are easily found and downloaded on the internet. These tools help to improve communication and understanding among health professionals. Since there are a variety of forms available, form selection should be based on what area you want to explore. Do you need a generalized tool, or are you looking for something specific? Mental status assessment includes level of consciousness, appearance and behavior, speech and body language, vital sense and self-attitude, mental health, for instance, mood and psychotic symptoms, and cognition. When assessing cognition, you could look at language, such as spontaneous speech and appropriateness of responses throughout the interview, which assist in assessing language function. In addition, the person can be asked to name objects that are pointed to or to repeat phrases that you give him. Memory. At the start of the examination, the person is given 3 unrelated words, such as dog, cup, bed, and asked to repeat those words and remember them. Midway through the examination and again at the end, the person is asked to recall those words. Attention and concentration. The person is asked to spell the word world backwards or to count backwards from 100 by sevens. Executive function. The person is asked to state what 2 words have in common. For instance, apple and banana, or shoe and sock, or coffee and tea. Or to list in a minute as many words as possible, starting with the same letter. The ability to follow a 3-stage command. The person is given instructions to follow with 3 basic acts, such as pick up that piece of paper, fold it in half, and hand it to me. Judgment. A situation that requires simple problem solving is presented to the person, such as asking what actions he or she would take if fire was seen coming out of the bathroom. As an alternative, the person can be asked to explain the meaning of a saying, such as, an ounce of prevention is worth a pound of cure. Visuospatial functioning. The person is asked to draw something, for instance, a face of a clock, or copy a simple diagram that demonstrates his or her ability to understand the spatial relationship of objects. When necessary, repeat back your understanding of the resident's responses to make sure that you are understanding correctly. To repeat, if this is a new admission, you are obtaining assessment information to establish a baseline, but recognize that those being admitted following a hospital stay are at increased risk for the onset of delirium. It would be important to find out from family members or others who know the resident to determine if what you are seeing at admission is usual for the person or if a change has occurred. How do we analyze data? We need to review our data to look for signs or symptoms of mood disorders, psychiatric illnesses, or problems in cognitive function. Delirium, dementia, and depression are of particular concern in long-term care. Documentation often refers to altered mental status, but what does that mean? Disruption to how the brain works that causes abnormal change in alertness, responsiveness, and/or behavior. Memory, affect, speech, thought process, mobility can be affected. Changes can be slight to profound. Changes in mental status can be caused by a variety of factors, such as an underlying illness. Changes in mental status with a rapid onset usually are associated with a delirium. Always consider that delirium is a possibility. Look for it. Delirium is characterized by multiple symptoms that reflect a change in mental status, usually triggered by an underlying condition or event in a vulnerable person. Predisposing factors are those characteristics or qualities in a person that make them more susceptible to delirium. There are multiple predisposing factors, some of which are listed on this slide. An individual can have one predisposing factor or many. Generally, older people have more than one of these factors. Long-term care residents often have many. Those with predisposing factors are vulnerable to the effects of precipitating factors, which are events or situations that trigger the onset of delirium. Consider how many precipitating factors are evident in your long-term care residents. And so we see that a person with a predisposition to altered mental status has a precipitating factor, then a delirium can occur. Not only is the incidence high, but the consequences are very serious and possibly deadly for the individual and detrimental to the healthcare system. If it goes undetected, it doesn't get treated due to variety of nature of the symptoms, confusing it with dementia and being unaware of factors that can cause it. Therefore, the potential for serious negative outcomes increases. It's important to be knowledgeable about delirium as it can be difficult to recognize the signs or symptoms. With delirium, there is a change in mental status that occurs within hours or a few days. Mental status fluctuates. There are disturbances in consciousness, attention, cognition, perception, and/or behavior. By definition, symptoms of delirium fluctuate, which makes it harder to detect. There are several types of delirium which further complicates recognition. For instance, hyperactive, hypoactive, and mixed. When we think of delirium, we often think of the symptoms of the hyperactive form. Be aware that the hypoactive form more commonly occurs in the older population, has the worst prognosis, and is the most frequently missed. If you don't know the resident, for instance, if he's a new admission, you would assume that problems with mental status could be associated with dementia. If you do not know the resident and the resident has dementia, it's often assumed that the dementia is getting worse. This may not be the case, which is why good assessment is important. Let's review some key points. If baseline cognition is unknown, changes go unrecognized. Symptoms often are assumed to be dementia. The prevalence of dementia in long-term care is reported as high as 40 to 60%. Those with dementia are at higher risk of other changes in mental status. Fewer triggers for delirium are required. Delirium in dementia hastens cognition and functional decline. Delirium and dementia result in higher hospitalization and mortality rates. It's important to recognize changes, which could include the usually oriented resident becoming disoriented to person, place, and time, new onset of memory loss, decreased attention span, difficulty concentrating, incoherent, illogical, or disorganized speech, the person becoming lethargic, difficult to arouse, or slower responses, increased or decreased motor activity from their usual pattern, restlessness or slowed motor function, rapid change in mood or behavior, for instance, the person is irritable or aggressive, a change in sleep patterns. Symptoms that fluctuate throughout the day may become worse in the evening or night hours. When we document that a person has a change in mental status, it would help to be specific about what we see. A concurrent review has to be initiated when we note a change in condition. We know by Maryland law that the nurse has to review the items on this slide when there is a change in mental status. Let's take a more specific look at behavior now. We need to recognize that behavior is communication and figure out what the resident is trying to say. When dealing with challenging behavior, it's important to note the specifics about when the behavior is occurring and what exactly it means. Analysis of behavior within the context that it occurs is important for identifying the trigger. Behavior management is based on attempts to eliminate or minimize the trigger. Once we have collected the data, we need to decode that behavior to try and determine the trigger. The behavior can be triggered by cognitive, psychiatric, or physical disorders, the environment, factors in the person's history, or the caregiver's approach or actions. In conclusion, the goal of this presentation was to help you to think beyond simple descriptions. Hopefully, you now have a better understanding of mental status, mood, and behavior, and how it impacts care, and are armed with better tools to help you with collecting and analyzing data so that you can communicate your assessment objectively and consistently. Please see the related files in this toolkit for additional resources. And thank you for your participation in this program.